Again, I'm going to talk a little bit about our research in diaphragm pacing and trying to help patients. So this is a little bit different than the first two talks. We talked a little bit about the ALS overall. I'm a general surgeon, so I'm a surgeon. And so for the last 13 years, I've been working on one muscle, both in our research lab and clinically, the diaphragm. The diaphragm obviously is critically important for breathing. I look around here and I see everybody's using their diaphragm. Actually, I looked around and I saw nobody on a ventilator right now. So I know every one of you at least has some part of your diaphragm working, even if you're on ALS right now. And so what we looked for over the years in these studies is to try to identify how we can help patients breathe better. And full disclosure, as some of you may know, is I founded the company called Synapse Biomedical with my university. One is we couldn't find any other company 7 years ago to build a device for it after we successfully implanted our first spinal cord injured patient. Our second spinal cord injured patient we ever implanted was Christopher Reeves. And so we've been working on this for a number of years with our first patients implanted over 8 years ago. Again, I want to talk a little bit about how we breathe and why that's important. As we all know in ALS, eventually you can't breathe and you either choose to go on a ventilator or die. In the United States, most patients choose to die as opposed to go on a ventilator. In certain other countries, such as Japan, about 70% of people go on ventilators. In the United States, it's somewhere between 5 and 10%. It's increasing a little bit, but it's still kind of the end point for most patients. If they have to go on a ventilator, they choose to stop their therapies. I'm going to talk a little bit about this pacing system that we've developed over the years, what our results are in spinal cord injury, and why that is really one of the key aspects and why we're seeing what we're seeing in ALS patients. And I'll kind of talk about our trials. We have overall about 140 patients already with the diaphragm pacing for ALS alone. Overall, when we think about breathing, this goes back to Dr. Piero's talk. ALS is a combination of upper and lower motor neuron involvement. And so the upper motor neuron is when we can make our diaphragm breathe, when everybody takes a big breath and your abdomen goes out, you're thinking about your diaphragm. As most of you are sitting here eating, you kind of have involuntary control of your diaphragm. You don't think about your diaphragm moving. We know that when you swallow, your diaphragm isn't contracting. It's all controlled in our brainstem. We know at night we have our diaphragm completely differently. The prebiotics complex in our brainstem controls our nighttime breathing. Completely different system at nighttime and in daytime. We've now identified in ALS patients that they do have this nighttime sleep dysfunction. That's why we recommend BiPAP for patients with ALS, because they have this inherent problem with their diaphragm, loss of control. We also know that you have to have these intact phrenic motor neurons. If you lose every motor neuron to your diaphragm, we can't stimulate the muscle. If we cut your phrenic nerves, so remember there's a nerve from our spinal cord to our diaphragm, if we cut the nerve completely, we can't stimulate that muscle. Our diaphragm is an incredible muscle. Evolutionary speaking, if you believe in evolution, amphibians don't have diaphragms. As we go higher up the evolutionary chain, our diaphragm actually becomes more controlled. We need to control our ventilation for our brain to maintain our brain activity. And you have better brain activity if you have better control of your diaphragm. Our diaphragm has what we call type 1 and type 2 motor units. Type 1 is a slow twitch, like if you're running a marathon. Our diaphragm is supposed to work every minute of every day. You never rest the diaphragm. And I'm sure as occasionally at neurology conferences where I talk a lot, some pulmonologists say you have to rest the diaphragm. Our diaphragm is never meant to rest. You never rest your heart, you die. If you rest your diaphragm, it starts having immediate changes in that diaphragm muscle. So it's a little terminology. People may say, I'm going to rest my diaphragm going on BiPAP, but really you're resting your accessory muscles. You don't need to rest your diaphragm ever. Type 2B muscle fibers is the fast twitch muscle fibers. And so what we know is most of you sitting in this room have about 70% type 1 muscle fibers and about 30% type 2. We've now realized ALS patients have a little bit higher percentage of type 2B muscle fibers, which means you can't utilize your diaphragm all the time, which means it tires out a little bit quicker. This is my diaphragm under fluoroscopy. So I did videotape my own diaphragm at an x-ray, and that diaphragm moves up and down. I show this video because I know those of you with ALS or loved ones with ALS, you know you go and get those pulmonary function tests, and it's hard to do that test. But that test really doesn't measure diaphragm movement. It measures what you can do with that test to form the seal. That forced vital capacity sometimes isn't the best test on whether or not your diaphragm works or not. And so the key thing is looking at it. Your diaphragm has to use 24 hours a day. It atrophies faster than any other muscle. If I stopped using my diaphragm for 12 hours, I'd lose 50% of my diaphragm mass. It would convert to type 2B. We have different gene expressions within the hours of our diaphragm not being utilized. This is the article that confirmed this. All of our animal work had recently always shown that, but we had never done a human trial. It's one of those articles where I wish I would have done it. I didn't publish this New England Journal article. It came out in March. It's an elegant study where they took brain-dead people when they harvest organs, so they knew exactly how long they weren't using their diaphragm. Because to be brain-dead, you can't be moving your diaphragm. And they compared it to people they took diaphragm biopsies off just during a regular surgical procedure. And they saw how rapidly the diaphragm atrophies, which is really why we really want to keep our diaphragm strong. And you can't think about moving your diaphragm because you can't do it all the time. It's this involuntary control, and unfortunately in ALS, people lose that involuntary control. If you look at that lower picture there that shows the type 1 to type 2B muscle changes, and this is our lab showing it in animals in 1993. And so all of our research really goes back quite a bit. We've been working on this for a long period of time, trying to maintain type 1 muscle fibers by electrical stimulating that muscle fibers. So a lot of the technology, and I'm kind of come from Cleveland. I'm one of 10 kids, so I always talk loud. Well, all my brothers work for Ford. And so interestingly, our initial wire winder, my brothers are tool and die guys. They actually built it themselves in their garage. So if anybody gets our device, it initially started in my brother's garage. And it's kind of just making a device, which is a little bit different than drug development. It's actually a little bit easier from FDA standards for medical device research than pharmaceutical research. This is the operation. So now you are eating, and I'm going to show you surgical pictures. Nothing that bad. Picture on the left there, or your right of your screen, is actually a laparoscopic procedure. I'm a laparoscopic surgeon. I could be taking out the spleen with that, adrenals, gallbladders, appendix. We look inside and we do whatever we need to do. On the right-hand side of your picture there, you'll see a gastrostomy tube. That's what a feeding tube looks like on the inside. If you see the background there, there's the wires on the inside also. We kind of designed this trial knowing that in the future, that I think at the time of a feeding tube placement, placing wires would be appropriate. It's interesting when you initially design your FDA trials, you want to make sure that it's okay to do both at the same time, so you don't have to go back to the FDA. There's some future surgical options that people may have heard about. It's called natural orifice transluminal endoscopic surgery. In our animal lab, we've actually placed this entire system through the pig's mouth at the time of a feeding tube. So we had some newer technology with doing surgery with no incisions. So people are taking out gallbladders and appendixes through the mouth now. We have ways of doing that, so we actually devised a way to actually show that we could place these wires in the future at the time of just a feeding tube without even really going into an operative procedure. This is what the diaphragm looks like, and this is very important, and what we call and the picture on your, I always think it's always, your left-hand side is actually somebody that was injured in the first Gulf War. Remember, most of our research started in spinal cord injury. So in the first Gulf War, this is a guy that actually had shrapnel injury to his neck, so he lost motor neurons. And so on the lower half of that diaphragm, you can see a denervated diaphragm. It looks completely different. And this actually, Dr. Piore was in the first operation we ever did on an ALS patient. And this is the picture where the first time we saw an ALS diaphragm. And then we kind of sat there and go, we can see the denervated areas. We can literally see the disease. And I think we coined the term radial banding of ALS. And so we still utilize that term because we can actually see the disease of the patient's diaphragm. It's actually a variable pattern of what's being gone. So it's something where we can actually tell at the time of surgery how bad that diaphragm is. What we identified, though, is that we can't just randomly put in these electrodes. We have to map the spot to find the right spot to put the electrodes in. So this is a functional test we're doing at surgery to identify that. That's a little suction cup electrode, and I actually stimulate the diaphragm. We see the contraction. I had previously done on the left-hand side one of our cadaver studies where we took diaphragms out of, obviously in Cleveland. I think Pittsburgh has the same amount of homicides as we do. I was able to get a fair amount of diaphragms pretty rapidly from my morgue to look at that. We realized you can't just randomly place these electrodes in. You actually have to find the spot to implant the electrodes. Then once we put the electrodes in, we can make the diaphragm move. Anterior part, posterior part, and both parts together. Now this is a spinal cord injured patient who hasn't moved that diaphragm in 25 years. Hasn't breathed in 25 years. The system's intact, and we just electrically bypassed the problem. And actually, initially, when we started this research in ALS, people said, well, all the lower motor neurons would die and you wouldn't be able to do anything in the end result. But as Dr. Piero said, there's always some upper motor neuron involvement, and we don't think all the lower motor neurons ever die off. As long as you can make the diaphragm move, you can maintain some ventilation in ALS patients. We also found some more interesting things. You heard a little talk about biomarkers. It's just about 18 months ago I realized we can read the electrodes we implanted. And I started doing EMGs, which is actually, as a surgeon, this is really stretching my knowledge base here. So I can read the EMG, which means we now have a marker for the disease for the next round of therapies.